All right, welcome back. So just going to recap a few things here. So last time I revealed to you that this patient had a mild, gently sloping to moderate sensorineural hearing loss bilaterally. And then the main focus of this case study was the vestibular components here. So I showed you a compare and contrast of two evaluations that were done. So you can see there those positional testing. I really emphasized the downbeating nystagmus to you in both evaluations. And then Dix-Hallpike, we were positive for BPPV the first evaluation and negative the second evaluation. Moving on here, name that pathology. So you guys had some really good guesses, and I can see where your thinking was based on case history and everything I presented to you. So a few of the guesses were vertebral basilar insufficiency, some sort of cervicogenic or nerve compression pathology, all great guesses, okay? But what I really wanted you to kind of try and figure out are some of those hallmark signs from this case. And that being said, this patient reported imbalance and gait was also observed to be abnormal. And another thing I forgot to list here, but the increase in severity of symptoms from the last time he was seen in 5/21 to 10/21. Now the downbeating nystagmus was present in both evaluations, and it's positional evoked. So it didn't suppress in any of the positional changes, and right there that can indicate a central pathology of some sort. So we've already got the central indication, and then at one point we had positive BPPV, negative for BPPV. So a lot of you were thinking some sort of non-localizing pathology at this point, and you're right on track with that, so that's great. So next steps, I asked you kind of what would be your next steps in care based on what I'd given you. Great ideas here as well, referral to neurology, maybe a cardiac specialist based on his congenital heart disease and some of the side effects associated with that. There was also referral for neuroimaging, so CT and an MRI. And again, that's also a great guess as well as to what we could do in our next steps of care here. So the reason I chose the rotary chair, I already knew the pathology the patient had that I'm going to reveal here shortly to you. So that's what helped me decide what I needed to do next. Now, if I didn't have that information and this patient I was seeing for the very first time and had not been diagnosed with this pathology, my thinking would have aligned a lot with many of yours. So next step for me was rotary chair with this patient. So from my findings, spontaneous nystagmus, I had upbeating nystagmus that did not suppress with fixation with this patient. So right there, a central indication. Gaze testing was abnormal. Those findings revealed upbeating nystagmus and corrective saccades present in all gaze conditions and did not suppress with fixation. So again, central indication. Saccade testing, abnormal findings revealed undershooting in horizontal and vertical conditions tested. Central indication there. Smooth pursuit, abnormal findings revealed reduced gain, saccadic component, and asymmetry in both the horizontal and vertical conditions tested. Another central indication. And OPKs, I did test 20 degrees per second, and that came back normal. But abnormal findings from this revealed abnormal eye velocity and velocity gains in the conditions of 40 degrees per second and 60 degrees per second. Now, 60 degrees per second, oftentimes your older patients, about 60 or older, may not be able to do this. So it's not considered an abnormal finding around that age, but this patient is much younger than 60 years old, so I would expect him to complete that task and it to be normal. But however, based on all the other VOR testing that had been completed prior to OPKs, at this point, everything was abnormal, so I was expecting OPKs to be abnormal as well. So Shaw testing, findings revealed normal phase and gain, which is great. However, asymmetry was abnormal, and I listed there the frequencies I tested. So an abnormal asymmetry indicates a lack of compensation at the vestibular nuclei, so our pathway all the way up to the cerebellum there. Therefore, a patient may also have spontaneous nystagmus, positional nystagmus, and directional preponderance. So we have 2 of the 3 right now. We have that spontaneous nystagmus and the positional nystagmus. Next was the VOR suppression. Again, already kind of thinking that was going to be abnormal, and it was abnormal, present but reduced, and falling outside of normal limits. So you can see for the subjective visual vertical, abnormal tendency to the left, and subjective visual horizontal abnormal tendency to the left as well. So the purpose of the subjective visual vertical or horizontal is to assess the vestibular function of primarily your otolith organ and central proprioceptive pathways. So if you see any abnormalities, it's kind of open to various interpretation, as it could either be both the brainstem or the labyrinthine site of lesion that may be affecting some of the torsional ocular system, and this comes right out of your Jacobson and Shepherd book. So going back to name that pathology, we have some additional signs now. We've got gaze-evoked nystagmus to add to our Hallmark sign list. Let me go back there for just a moment. So I wanted to touch on that gaze-evoked nystagmus. You typically see a lateral inferior gaze or oblique lateral down gaze. In this case, it was apparent the veteran presented with more of a lateral superior gaze or an oblique lateral up gaze instead of the down gaze that one person had guessed would be present in the ocular motor subtest. So, since I had already shown you briefly there, this is actually Arnold Chiari malformation type 1. So this is a patient that is post-surgery, completed in 2018, and is now having persistent symptoms with increased severity of severe imbalance, vertigo, nausea, vomiting, headaches, and falls. To kind of recap what Arnold Chiari malformation is, it's a problem in which part of the brain, so the cerebellum, at the back of the skull begins to bulge through a normal opening in the skull where it joins with the spinal canal. This puts pressure on parts of the brain and that spinal cord and causes mild to severe symptoms. In some, but most cases, the problem is present at birth, so it is congenital. And as we know, the cerebellum is part of the central vestibular pathway. So all that information is being taken up, and then the brain there is trying to process that information and have an output. So that's where you start to see a lot of the imbalance occur, because the brain is not able to take in that information and process it in the way that it wants to. So then you can kind of think of it as remapping its way back down, trying to get that information up there and out of there. And as a result of it, that's where we begin to start seeing some of these vestibular symptoms occur. So the other thing with Arnold Chiari malformation type 1, It's really interesting with these patients, especially this patient, because I was doing a little bit of research trying to figure out, okay, well, why is this patient presenting with such severe symptoms after surgery about 3 years later now from that surgery? In a lot of cases, patients will find relief from their symptoms after surgery, but we just don't have a lot of post-surgical data to go off of. So it's kind of hard to determine pre and post-op outcomes. I just really find it interesting now that it's 3 years later and symptoms are becoming more severe again. So I'm wondering if there is something else going on, either if it's related to the Arnold Chiari surgery, or maybe it's some other neuro endings that are being impacted from that surgery. So we'll kind of see. I haven't gotten any results back yet or seen him back for any further testing. So I'm still very curious as to what the outcome with neurology was with this case. Now for assessment, so this is a non-localizing case. You have some peripheral indications, you have some central indications with it. So it was noted in our results that it's more indicative of a brainstem site of lesion. However, there's low suspicion of peripheral vestibulopathy at this time, even though there's that presence of BPPV from the first assessment, and then we didn't have it the second assessment there in 1021. So our suspicion is primarily a central finding from the data that we collected. What's interesting is that this population has the highest rate of benign paroxysmal positional vertigo reoccurrence. So it kind of makes sense. He has these vertigo attacks and then things resolve for a little bit. We, do some repositioning, canalith maneuvers, and then he comes back and everything's okay. So I will be interested to see if he comes back for the BPPV portion of this. But like I said, mostly at this time it's non-localizing findings, so we'll see what happens. Now, what I recommended in his plan of care, knowing the information that I know and the pathology that had already been diagnosed back in 2018, neurology was actually the one that sent over this consult. So I just made them an additional co-signer to make sure that they reviewed my findings. And again, we can't rule out the CNS involvement at this time. And then I recommended further imaging for this patient, just that we, cover our tracks here and make sure that nothing else is going on. And then also to follow up with primary care or neurology with considerations of referral to optometry for further ocular motor testing. It's probably going to be more ophthalmology, but I can't do a direct referral to optometry. I have to go through primary care or neurology. So this was just a recommendation to them and kind of what I was thinking. And then, if optometry gets the case first, if they have other findings, they'll refer on to ophthalmology as well. So interesting case. You don't really get Arnold Chiari malformation patients, but this one was interesting for the fact too that it's post-op. So in future, if you want to take a look at this resource I found, this talks a little bit more about decompressions in Chiari malformations, specifically more so to the post-op testing that's done and kind of the results that they have found there. So thanks for watching, and great guesses on everything and good thinking with next steps.